Before we jump into the problems, let's do a quick refresher. When doing ABG problems, you want to look at the pH, the PaCO2, or the levels of carbon dioxide within the blood, and bicarb, or HCO3 in the blood. With pH, the normal pH is between 7.35 and 7.45. If the pH is less than 7.35, we are in a state of acidosis. If the pH is greater than 7.45, we are in a state of alkalosis. The PaCO2, or the level of carbon dioxide within the blood, normally ranges between 35 and 45 millimeters per mercury. Think of carbon dioxide as an acid, so the more you have of it, the more acidotic the state is. The less you have of it, the more alkalotic, or the more basic the state we're in. And then for the bicarb, think of bicarb as a base, so the more you have of it, the more alkalotic the state we're going to be in. The normal bicarb level is between 22 and 26 milliequivalents per liter, but some sources say it's between 22 to 28. So I recommend you go with the range that your professor or your textbook or your worksheet wants you to go with. So if the bicarb level is less than 22, we are in a state of acidosis. If the bicarb level is greater than 26, we are in a state of alkalosis. And when solving ABG problems, it helps to know the acronym ROME, which stands for respiratory, opposite, metabolic, and equal. Respiratory, opposite. So this tells us that if the ABG situation that we're dealing with is a respiratory issue, whether respiratory acidosis or respiratory alkalosis, the pH and the CO2 are going to be moving in opposite directions. If it's respiratory acidosis, the pH is going to be low, lower than normal, and the CO2 is going to be high, higher than normal. If it's respiratory alkalosis, the pH is going to be high and the CO2 is going to be low. If the ABG problem that we have is a metabolic issue, whether it's metabolic acidosis or metabolic alkalosis, the pH and the bicarb are going to be moving in the same direction. So for metabolic acidosis, the pH and the bicarb are going to be both low, lower than normal, so they're both going down. And the pH and the bicarb, if they're moving both up, they're both increasing, then we are in a state of metabolic alkalosis. Before we jump into the problems, let's quickly talk about the compensation status. So if we have an ABG situation in which the other system is normal, then it is non-compensated. If we have an ABG situation in which the other system is abnormal and the pH is abnormal as well, we are partially compensated. The other system being abnormal tells us that it's trying to help, so that's compensation, and the pH being abnormal tells us that it's partial. If the other system is abnormal and the pH is normal, this tells us that we are completely compensated, meaning the other system being abnormal is trying to help, and the pH being normal means that the other system was able to help stabilize the situation for the pH to be normal. So it's fully compensated. Now let's jump into the problems. So for our first problem, we have the pH of 7.41, which is normal, the PaCO2 of 41, which is also normal, and the bicarb of 22, which is also normal. So this is a normal situation. There's nothing going wrong with the respiratory or with the renal system. Now let's move on to our second problem. The pH is 7.47, the CO2 is 30, and the bicarb is 25. Remember that pH ultimately determines if we are in a state of acidosis or alkalosis. So the pH here is higher than normal, so we are in a state of alkalosis. So in order to determine if we are in a state of respiratory alkalosis or metabolic alkalosis, we have to use ROME. So let's look at the level of CO2. It's 30. It's lower than normal. CO2 is an acid, so less CO2. It's less acidotic and more alkalotic. The bicarb here is 25, which is within normal. So because the pH and the PaCO2 are moving in opposite directions, this is an example of respiratory acidosis. And because the bicarb level here is normal, this is non-compensated. Moving on to the next problem, the pH is 7.32, which is lower than normal. So we are in a state of acidosis. The PaCO2 is higher than normal. And the bicarb is higher than normal. So here, the pH and the CO2 are moving in opposite directions. So this is a state of respiratory acidosis. Since we know this is a respiratory acidosis situation, we know that the problem system is the respiratory system. And so looking at the bicarb is higher than normal, so it is trying to help. However, the pH is still abnormal, so this is an example of respiratory acidosis with partial compensation. For our next problem, the pH is 7.28, so that is lower than normal. So we are in a state of acidosis. The PaCO2 is lower than normal. And the bicarb is lower than normal. So because the pH and the bicarb are moving in the same direction, this is an example of metabolic acidosis. Since we know this is metabolic acidosis, we know the problem system is the renal system, represented by bicarb. So when we look at the CO2 levels, it is lower than normal. It is abnormal, so it's trying to help. However, the pH is still not normal, so this is an example of partial compensation. Moving on to the next problem, the pH is 7.5, which is higher than normal. So we are in a state of alkalosis. The PaCO2 is within normal, and then the bicarb is higher than normal. So because the pH and the bicarb are moving in the same direction, this is metabolic. So this is an example of metabolic acidosis. Because the CO2 level is normal, this is an example of non-compensation. Moving on to the next problem, the pH is 7.35, which is normal. The PaCO2 is 60, which is higher than normal. and the bicarb is 35, which is also higher than normal. In order to use Rome to determine what ABG situation we have to look at the pH. The pH is 7.35, which is normal. However, 7.35 is closer to the acidotic end, and so I'm going to draw a down arrow. With this, we can use Rome to figure out the ABG situation. The pH and the PaCO2 are moving in opposite directions, so this is an example of a respiratory issue. And so while the pH is normal, it is closer to the acidotic end, so we're going to consider this as respiratory acidosis. And as for the bicarb, we see that it is abnormal, so it's trying to help neutralize the situation. So that means we have compensation going on. And we know that this is full compensation because the bicarb was able to help neutralize the acidosis to the point where the pH has been normalized. So now for our last problem here, we see that the pH is 7.32, which is lower than normal. So we are in a state of acidosis. The CO2 level is higher than normal, and the bicarb is lower than normal. So since we have the pH and the CO2 moving in opposite directions, we have respiratory acidosis. But if you look closer, you see that the pH and the bicarb are also moving in the same direction. So we have metabolic acidosis as well. As for the compensation status, compensation is not possible here because you have a problem with the respiratory system and with the renal system. So you can't have one system try to help out the other because they're both struggling. We're going to start off by talking about respiratory acidosis. What causes respiratory acidosis is hypoventilation. In other words, a person is breathing too slowly or their breaths are too shallow, and so you're going to have a retention of carbon dioxide. So hypoventilation would look like being oversedated. It would look like having COPD or any other condition in which air is trapped and you have an increase in the level of carbon dioxide within your system. You could also have respiratory failure or respiratory arrest. And pulmonary edema, just to name a few. Carbon dioxide, think of carbon dioxide as an acid. So if you have higher than normal levels of carbon dioxide, that puts us in a state of acidosis. Alternatively, if you have lower than normal bicarb, that puts us in a state of acidosis as well. But this would be more applicable to metabolic acidosis. So then how are we going to treat this? So to treat respiratory acidosis, you need to treat the underlying cause. So this would look like giving someone who's experiencing COPD bronchodilators to open up their airways, giving them corticosteroids to reduce the inflammation, to increase the ventilation, improve their oxygenation, and help bring down the levels of CO2. Another way we can treat respiratory acidosis is to increase the number of respirations. Because remember, the cause of respiratory acidosis is hypoventilating. A person isn't breathing enough. So we need to increase their breathing rate. And another really simple thing that can be done is to elevate the head of the bed, because this promotes oxygenation. Now let's move on to talking about respiratory alkalosis. With respiratory alkalosis, the cause is going to be hyperventilation. So what's happening here is that a person is breathing too much. And so this excessive respiration is going to decrease the amount of CO2 because they're breathing so fast that they're essentially blowing off the levels of carbon dioxide. And remember, think of carbon dioxide as an acid. If you have higher than normal, that puts us in a state of acidosis. If you have lower than normal, which is what is going to be present with respiratory alkalosis, that's going to put us in a state of alkalosis. So a person hyperventilating, meaning they're breathing more than normal, could be due to them being in pain. If they're anxious, or if they have a condition such as pneumothorax, which increases their respiration. So what we're going to do to treat respiratory alkalosis is we need to treat the underlying cause. So let's say someone is hyperventilating to the point that it's put them in a state of respiratory alkalosis. And we know that this hyperventilation is due to pain. So by treating the underlying cause of pain, giving them pain medicine, that's going to help bring down their respirations to normal. By bringing their respirations back to normal, this is going to help stabilize them and take them out of respiratory alkalosis. Another thing we can do to help treat respiratory alkalosis is to reduce the number of respirations. And this makes sense because with respiratory alkalosis, what is causing it is hyperventilation. A person is breathing so quickly that they are blowing off a lot of carbon dioxide. And if our carbon dioxide levels are lower than normal, that puts us in a state of alkalosis. And so another thing that can be done is by breathing in into a paper bag. And what breathing into a paper bag does is it allows a person to rebreathe the carbon dioxide that they're blowing off. This is going to help increase the level of carbon dioxide within their blood to help stabilize them and remove them from a state of alkalosis. But we don't want them to breathe in too much of the carbon dioxide because if their carbon dioxide level is greater than normal, that's going to put us in a state of respiratory acidosis. Now let's move on to talk about metabolic acidosis. The cause of metabolic acidosis is going to be either acid gain, or bicarb loss. So let's talk about bicarbonate loss first. Bicarb is lost through the feces. And so in the case of diarrhea, where someone is excessively defecating, they are also excessively losing bicarbonate. And you have to recall that lower levels of bicarbonate, lower than normal levels of bicarbonate, results in acidosis. Because think of bicarb as a base. So if you have lower than normal, it's less basic, it's less alkalotic, and it becomes more acidotic, the situation that we're in. Bicarb loss can also look like bile drainage. You're losing bicarb there as well. And as for acid gain, this is going to look like a person who has kidney failure. The kidneys are responsible for reabsorbing bicarb from the urine. And so if someone has kidney failure or their kidneys are injured and they can't work as efficiently or work as well as they're supposed to, you're going to have a lot of bicarb loss through the urine, putting us in a state of acidosis. Additionally, if someone is in a state of DKA or diabetic ketoacidosis, or if they're in a state of shock, that is also going to increase the amount of acid that is within their blood, putting them in a state of metabolic acidosis. So then for the treatment, you of course want to address the underlying issue. So let's say someone is in the state of metabolic acidosis, and the cause is DKA, diabetic ketoacidosis. So by treating DKA with fluids and insulin, that's going to help stabilize the patient and remove them from a state of acidosis, metabolic acidosis. So now let's talk about metabolic alkalosis. With metabolic alkalosis, you are losing acid. So this is going to be due to things like vomiting. When you vomit, you're expelling the acidic content of your stomach. Alternatively, gaining too much bicarb can cause metabolic alkalosis. And this can be due to things such as hyperaldosteronism, where you have excess steroids in the body. And there are some steroids in the body that increase the kidney's retention of bicarb. And that excess bicarb gain puts us in a state of metabolic alkalosis. Another cause of metabolic alkalosis is having low potassium levels. And this could be due to excessive diuretic use. And so just like the other situations, the treatment will include treating the underlying cause. So because we have a high pH and a low CO2, this tells us that we are in a state of respiratory alkalosis. Because the bicarb is lower than normal, it's not normal, that tells us that there's some compensation going on. How do we know this is full versus partial compensation? We look at the pH. Because the pH is still out of the normal range, this is considered partial compensation. If the pH were to be within the normal range, as we see in our next problem, then we would consider it fully compensated. So for this problem right here, we have respiratory alkalosis with partial compensation. So what does that mean? It means that we have a person who is maybe in pain, and because they're in pain, they have very high respirations, putting them in a state of respiratory alkalosis because they're breathing off too much carbon dioxide. And so what the kidneys are trying to do now is to increase the excretion of bicarb to help address the situation. Remember to think of bicarb as a base. So if you have higher than normal levels of bicarb, that's going to put you in a state of alkalosis. If you have lower than normal levels of bicarb, that's going to put you in a state of acidosis. So by the kidneys excreting bicarb to lower the levels of bicarb, that's helping to introduce some more acidity to this situation that we're in, which is alkalosis. So it's trying to help fix the problem. So the situation we have here is metabolic acidosis with full compensation. Let's translate that. This means that we have someone who is maybe in DKA or maybe in shock, and so that's causing them to be in a state of metabolic acidosis. So what the kidneys are trying to do here is to reabsorb bicarb from the urine to help increase the bicarb levels to help stabilize or to help neutralize the acidosis we're in. And since the pH is 7.35, which is normal, that means that we have enough bicarb that has helped to stabilize or to neutralize the acidosis to the point where we've been able to normalize the pH. So we are fully compensated. In one of our past videos going over ABGs, we had a problem in which the ABG situation was metabolic and respiratory acidosis. The pH and the CO2 are moving in opposite directions, so this is respiratory acidosis, and the pH and the bicarb are moving in the same direction, so this is also metabolic acidosis. So in a situation like this, what is happening is that we have someone who has maybe COPD and they are in a state of diabetic ketoacidosis. The COPD is causing the respiratory acidosis, and the DKA is causing the metabolic acidosis. An alternative explanation to what might be causing a situation of both metabolic and respiratory acidosis could be someone who has pulmonary edema and they have severe kidney failure or renal disease. Right. Another explanation we can provide for this situation is that we could have someone who has, let's say, pulmonary edema and they have renal failure. The pulmonary edema is what is causing their respiratory acidosis, and the renal failure is what's contributing to the metabolic acidosis. And so because both systems are struggling, there's no compensation that can occur because there's not one system that can help the other. So what we're going to do for this is, just like all the other situations, you are going to treat the underlying cause. With COPD, give those bronchodilators, give those corticosteroids, open up the airways, reduce the inflammation, improve oxygenation. By the way, that little rhyme I had going on was totally unplanned, but I hope you enjoyed it well enough to like, subscribe, comment, and share this video. It's not over yet, but I just wanted to point that out. So you want to treat the underlying cause, you want to treat the COPD, and you also want to treat the DKA by giving the person insulin and fluids. I hope this video helps. Please like, subscribe, comment, and share.